We're now into the discussion section, so please raise your hand if you have a question for the panelists. As the moderator, I'm going to take the prerogative to ask my question to you. When you placed on the screen earlier a list of challenges, perdiamitis, a series of things that complicate the effectiveness of in-service training, I wondered if you could say anything about approaches that you've seen that have rendered training more effective in your experience when tackling that long list of challenges that you documented.
I guess that's an excellent question. I'm sure everybody around the room would have something to say on that. And I'm now moving well into the terrain of anecdote. I think one thing the official title was in-service training. I think what we have often neglected is pre-service, and the fact that if we don't prepare people pre-service for being better practitioners, and I think this goes much more widely to the understanding what quality is and what professionals' role is in quality. I think that can be much more efficient. I'm not saying it's very easy because you have to deal with people who run curricula. In terms of training, I personally believe that if you want to change a person's skills, you need somebody skilled to train them, not somebody who's just heard the message a week before. And I think you need to create a critical mass of people who all now know and understand the same thing. So I think those are maybe three short answers.
Questions from the panel or the floor, please.
Hi, this is Bill Tierney. This is for Javier. When most of what you were talking about, I was perceiving it as being, I'm supervising someone who's delivering a service to a patient or a client or something like that. But we work in multidimensional organizations. And so, I mean, I've been the chief of medicine in a large health system, and the CEO of my system would have to supervise people who are supervising people who are supervising people who are actually doing the work. And the skills that are necessary and the tactics and the tools that are used are different at different levels. And in some places we call those things leadership development rather than supervision. But I think if really going to talk about supervision, it really has to be throughout an organization, because any place that breaks down and the whole system breaks down. So if you want to improve the quality of care and quality of ambulatory care in an organization, it may have to start with a CEO who has to then manage the chief of medicine, who has to then manage the chief of ambulatory care, who then has to manage the people who are the CEOs of each one of the practices, who then have to manage the clinicians. And the whole thing breaks down if you don't have management and supervision at each one of those levels. And so I think it's complex, but successful organizations figure it out.
Javier, any reactions to the comment that Bill has offered here about management and supervision at varying levels of a health system?
Thank you very much for this observation. I think it's extremely pertinent, and I cannot agree more. But you are right that we were focusing mainly in our work in the last, if you want, in the last in the last link with the with the expansion of the health districts and let's say the health workers working in isolation and so on. That certainly was our focus. But you are plain right, and thanks for this observation.
Other questions from the committee or from the audience? Yes, Jishnu.
Sorry, I guess this is to the panel. I'm just trying to understand a little bit how the interventions scale up or down. So, for instance, I can see, say your approach of working in a hospital where there are a lot of births taking place, but say in India where 80% of deliveries are in single-person clinics, would the approach be the same? And then would the cost just go up enormously? Is there a minimum scale you're thinking about for implementing these approaches? How does that work? I'm just
we have this work in India right now, but also we've had it in Afghanistan, which is completed at this point, where 80% of the deliveries are at home by birth attendants, and basically we set it up at the community level, where the birth attendants are part of the improvement team, and they go out to the homes and they deliver in the homes. The same thinking is applied contextually to make it work. And it is, you work at one district, one region in the district, and then you sort of scale it up to the district and you take it to other districts. And right now we're out of Afghanistan, but the Ministry of Public Health of Afghanistan is actually scaling up these interventions independent of the project.
Hello.
I have a question for Masood. Yes. Are breakthrough collaboratives only to address clinical topics, very specific subject matter topics? And then I have a comment.
The answer is they can address clinical topics, they can address managerial topics. We've dealt with like waiting times, we've dealt with files, records that are lost, we completed records, etc. They're also, you can adapt them and use them for large systemic issues like the one I showed with HIV/AIDS care. I think at the previous meeting in November, I showed dealing with redesigning the neonatal system of care in the Russian Federation. You can adapt them. The thinking can be adapted at multiple levels and for various things.
How do you identify the subject matter in which you are going to apply collaboratives?
Well, we here in our work, we are guests in somebody's home. We get invited to go to a country. So our remit comes from the government of the country together with USAID, and we address the priorities that they identify. Every now and then, since we're on the ground, we may identify other things, but that would be a conversation, and if they agree to it, then we would be able to work with them. In the US, it's a little bit different. IHI does a lot of this work as well. And there, the IHI identifies topics for intervention, and they basically launch initiatives to address them. It depends on where we are, but in our work, we're normally not doing that.
Thank you. I have a comment. Another subsequent question is for Mike. You did a great presentation about clinical in-service training because it was related to training, but it wasn't training. It's thinking about training. So you mentioned that training it has been thought of as a quick fix, and those of us that work in family planning may remember that we talk about training people to do vasectomies, and if you train them, the vasectomy clients will come, but that is not the case. So we are now trying to add other components to the clinical training, like service initiation support or increased follow-up to the trainees. Do you have information about other things that we need to do with clinical training to improve the impact of it?
I guess the short answer to your question, Camilo, is no. I think this goes back to comments made from the start of the morning. An intervention needs to be designed for the context, and that means people need to first understand the context and what are the gaps. So that you can have a generic framework, but that doesn't mean to say you will. That doesn't mean to say you will use the same recipe everywhere. And so I can tell you about the kind of things that work in my context, but I wouldn't know necessarily whether they would work everywhere. And I think it's that first. The trouble is that it'll probably take you 6 months to design and affect what you think is the best intervention, and then you need to be testing it. And if you don't know which components you think are valuable, then they're a question then. you need to ask the question as you do the evaluation, is that bit that I thought was going to work working, or actually maybe I should replace it with something else?
Thank you very much, Mike. In the back of the room, Nicole.
Yeah, thank you. Nicole Spicker, Farm Access. I have a question for Javier about the supportive supervision. Because a lot of the examples that were shown were about frequency and number of visits, number of hand-holding. But I was just wondering if there's any evidence relating to enforcement and incentive mechanisms. Because I think a lot of these visits, inspectors, if they even show up to the facilities, they will come there, but they will, if they're lucky, they get a report, but there's no consequences as a result. It's also very difficult to enforce without having to close down every healthcare facility. And where governments have tried, I know Mike English is probably familiar with this as well. In the Kenya model, facilities know when the inspectorate is coming, they close the facility, wait for them to pass, and then open up again. There's examples in Ghana, an accreditation mechanism, where there's actually a whole private sector company that now rents out equipment for you to be in your healthcare provider when the inspectorate comes, and then it rents it to the next hospital again. I was just wondering if there are some examples where enforcement and incentive mechanisms have actually added value, or is this something that still needs to be tested further?
Javier, that's a question to you, if you can.
Yes.
Yes, please.
Thanks for your question. Actually, no, that I am aware. Certainly for incentives, yes, but for reinforcement kind of thing, no, I'm not aware of any. I am in another field. I am aware of some types of interventions, some type of reinforcement interventions, or even legal interventions in the area of vaccination, where they have shown to be relatively effective in improving coverage, but not in the area of supervision and quality of care.
Thank you very much. The gentleman in the back.
Thank you very much, and thanks to all the panelists for their excellent initial presentations. I have a question for Xavier, though. You may have mentioned it and I missed it, but in your review of supervision, I was wondering whether you came across any studies that looked at the quality of the supervision, or whether that is another area of quality that needs to be further explored.
Yeah, well, that's a very interesting question. Very interesting, because this relates very quickly to our headaches when we were actually planning this review, because of course in the review you have to define your PICO question, your participants, intervention, comparator, and outcomes. And for us, the outcome was quality of care. So we wouldn't think in this context, in the context of this research, we wouldn't think about the quality of supervision. But we would certainly be faced with different types and components in the interventions that could suggest, if you wish, better quality or less quality. For example, if a supervision intervention is supported by a more thorough training, or is supported, by some tools like checklists or guidelines and so on. But we wouldn't work it out as the quality of supervision in this case.
Very good. Donna.
Thank you very much. Thank you to all the presenters. My question is to all the presenters, actually looking at, I would welcome your comments on how you have got community engagement in your various initiatives, and also how the voice of the patient comes through. So I would welcome your comments on that, please.
Sure. Community engagement. As in the presentation this morning, it's extremely important to have a compelling aim, something that really matters. And if that aim is compelling to the providers, to the leaders in the system, it usually is also compelling to the people in the system. And that starts to get a lot of engagement around it, and work has to be done to get people on board at the beginning. And usually the data helps, the presence of superior alternatives helps, etc. And the second part of the question was about voice of the patients. I probably missed saying that, but oftentimes, and more often than not, either patients or are involved on the teams, or alternatively, they're asked about their viewpoints and their input on the redesigns. We've had multiple teams that have had patients on them and have engaged the patients that way and gotten their perspectives. Thank you.
Rashad, to clarify, the teams that you're referring to are the facility level improvement teams?
And community
And
level
community,
teams.
okay. All right, thank you. Mike, do you want to respond?
Yeah, thanks for the question. So I think, I guess in our own work, we're dealing with multiple communities, from the Ministry of Health as one set of stakeholders to hospital managers, CEOs, professional associations. And that kind of engagement just takes lots of footwork, I think, to be honest, and an investment of time. And as Rashad has said, it's important to address what they're interested in, while sometimes making the case that there are things they should be interested in but don't appear to be. I have to say that I think, in my experience, and certainly in our own work, we'd have to say we're very weak at true patient voice. I'm not sure how well developed that is in many other low-income countries, but it's been much neglected, and I think it's hard to get at, and I'm not sure that doctors are often the best people to be doing it.
Javier, do you want to say anything about this question about community engagement or voice of the patient in supervision practices?
Well, I think that this is a very pertinent comment, and we are really in the infancy of considering how the community can actually be part of the health system. There are examples. The advantage of not being in the room is that while the others are talking, I am actually reviewing my documents here, but I couldn't find the exact place. But there were some example, or at least one example, of staff being supervised by community members. And also, when you look at all these initiatives of integrated community case management, you see different ways where community participates. For example, in the selection, it's not exactly supervision, I agree, but the community intervenes, for example, in the selection or in the establishing the criteria for the selection of community health workers and so on. And if you allow me, I would go back to this thing that is worrying me a lot lately, which is this issue that we don't have an analytical framework to understand the health systems. Therefore, despite that we have some ideas of how communities can interact, and and we have these very inspiring 7 roles of communities that Donna Bedian described for the population to participate in quality of care. So despite having these very inspiring ideas, we still don't have an analytical way to understand the different components of the health system, therefore including communities.
Sure, Mike, go ahead.
Sorry, maybe just I wanted to make another point, which is I think is related. And so in one sense, patient voice maybe has 2 crude aspects, I would suggest. One is that they're determining the priorities for what needs to be addressed, what's important to them. But the other is then the holding to account. So they're an audience to which the healthcare system should be accountable. But that whole accountability issue, I think, is hampered by this absolute lack of information. So even within the health setting, we don't hold health workers to account, ourselves to account, because there are no information on what we do. So I think the accountability issues are broad, and also linked to the fact that we don't just have good information on what happens routinely.
We just have a handful of questions, and we're going to close the session. Bill, one more from you.
Real briefly, I wanted to emphasize something that Rashad said, and that was the wisdom of the people practicing in the trenches, the collaborative model relying on them. In my own practice, we had a terrible problem with diabetic foot ulcers, and we tried to get the physicians to examine the patient's feet and record it. We couldn't do it. Education didn't work. We even tried computer reminders. It didn't work. And then a nurse figured out, just take the patient's shoes off. and then the feet got examined. I worked for a dozen years in Kenya, and the people practicing the trenches, it's a very hierarchical system. The people practicing the trenches, you know this, that they're very deferential to and intimidated by people in authority, and they will not speak up. And so if you want to, I'm sure you had the same effect, so if you want to engage them, you have to engage from the bottom up. They have to be running it, and then I think you'll get something from it. But if it comes something from the top down, I don't think you're going to really get the wisdom that truly will improve the quality and transform these systems.
Thank you for that comment. We have a question in the back.
Yeah, I'm Dr. Thompson with Health Consult International. WHO has 6 components of the health system, and out of those which are known as inputs, the outputs are realized. And output has to do with performance, which is divided or has quantity and quality. From the different tools that we have, and especially in the African context, where there are times when the population and the community is large enough, and you are interested in some performance which is acceptable vis-a-vis the volume of clients or patients and the few health workers or health force, labor force that is available. Would you now at this point say that you have done some comparative studies between output in terms of quantity and quality, and situations where you really want to promote quantity over quality, or at all points you are encouraging quality, especially as we have seen similar situations under the HMOs here where they are like, hey, we want doctors who can see a patient in 10 minutes than you see the patient in 1 hour, and those affect quality. They are interested, I believe, in quantity and not quality in that context. And similar things appear applying in Africa. Would we say that that's a bad setup of practice, is poor quality practice, or there are situations where you have to contextualize? Thank you.
Thank you for the comment. Any reactions from the panel?
Sure. I would say that we don't want high volume of poor quality care. That's of no value. If we are providing poor quality care, that's a waste, and it would be probably far better for us to provide the right care and not waste the resources on poor care. And oftentimes where this has happened, we found that if you do the right thing and don't do anything but the right thing and don't do the wrong thing, you actually save time and can get through more patients doing it. These were some of my early experiences and improvement back in my home country, actually.
Thank you, Rashad. There's one final question from Dinesh.
Yeah, this is linked with both training, supervision. One of the things we've seen in frontline is the management capacity at frontlines really makes a big difference in terms of service delivery. With your training hat on, Mike, what would you think? Is that an area? Because when we talk about training, I was thinking that we were focusing very much on the technical skill building, but the softer aspects of frontline management, capacity, team building, working are things that really possibly could also show results.
I think Alex, I'm not sure whether Alex will cover this later, maybe not. My understanding, so the effective practice of care group, effective practice and organisation of care group of Cochrane have done a large number of systematic reviews on some of these topics. And again, most of the time, my understanding is that there is little evidence to support many of these approaches. They all make intuitive sense, but that doesn't necessarily mean that we've been able to show in good, well-designed research studies that they actually impact. So I think even with those things, how do you create teamwork? So there are Cochrane reviews on interprofessional collaboration and trying to promote it. Results extremely disappointing. So there's a lot of things that we naturally try and believe in because they do make sense, and we've not often subjected them to particularly rigorous examination. And I think we need to try and move that forward agenda. But I think maybe what you're getting at is a much wider issue, and one of the I think the problems for sustainability is often what we're trying to do, and I think this goes to Dr. Tierney's point, is we're trying to create a whole culture in which quality is important. And I don't think any one intervention is going to do that. And it's a long-term agenda. And again, I would go back to, if a manager doesn't know what their frontline providers are doing and can't actually say, well, this is how many patients you saw, and this is how often you did this bit right, then it's quite hard for them to manage effectively.
Well, that may be a good place to stop. Thank you for the comments, and thank you to the panel, Mike and Rashad, and Javier, thank you for joining us in your evening in Basel. So thank you to the panel again. Move to a break.
And we'll be back in 15 minutes, please.